Thank you, and I'm delighted to be here representing pediatrics, nursing, the society, and everybody else who wants to lay their claim to give this talk about relatives. I have nothing to declare. We talk about relatives, and let's just start by defining it. And if you just look it up in the dictionary, it's a person that's connected to somebody by blood or by marriage. There are other definitions that expand that to more of a social construct. But when we really talk about relatives in the ICU, I would argue that it's an interchangeable word with family. And if we look at the family care guidelines published in 2016 by the Society of Critical Care Medicine, which are currently under revision, we can see that they define family as anybody that the patient says it is, who's important to them. And I think as a community, a healthcare community, we need to embrace that as the family. So I'm just going to talk about the family in the ICU and how we do all that, and we're going to buzz through some studies really quickly and hopefully have time at the end for questions. So this first one I want to talk about was published last year. These authors tried to assess family presence and the effect of the prevalence and the duration of delirium. It was a retrospective study done pre-pandemic for 4 years, looking at greater than 25,000 adults in Canadian ICUs. And they measured family presence, and the way that they measured that was either physically being there or on the telephone. They devised a natural learning in the EMR to pull that out of the EMR, so that they could do that retrospectively, and they determined whether or not families were there, called, or they weren't there at all. They also did the intensive care delirium screening checklist, and like I said, the outcome was delirium. So these are the patients, and like I said, a total of greater than 25,000, and I'd like to call your attention to the no visit column. You can see that those patients were much more likely to be admitted electively after surgery. They were less sick as measured by 3 tools, the Apache, the Carlson, and the SOFA score, and they were much more likely to be with it with GCS greater than 15. If we look further at their severity of illness, you can see they were less likely to be on vasoactives. They were not invasively or non-invasively ventilated, and fewer received CRRT. But what really were the outcomes? So the incidence delirium in the overall cohort was that physical presence was associated with a greater incidence of delirium in the unadjusted analysis. And they could then see, after adjusting, that those patients that had elective surgery and had an increased GCS, they had family presence, and that was associated with less delirium. And the duration of delirium in all comers was less for those who had physical presence and calling, family calling. I want to add, though, that the importance of these studies with family presence and delirium is identifying benzodiazepine use, which we all know has been associated with delirium. So I think we have to think about that particular piece of all of these studies that specifically look at family presence and whether or not these patients are receiving medications that we know have been associated with delirium. So this study was followed up by editorial in intensive care medicine, and sort of pointed out the things that I told you about, that this group with less delirium, they weren't the same as the other sick patients. So instead what they offered was that family presence isn't a risk factor for delirium, like the study may have you think, but rather a collider with severity and poorer outcomes. So moving on to studies in a study in Iran, they wanted to know if family presence during weaning decreases intubation time. That was a very clever take on the whole process. This was a quasi-experimental intervention study of 154 patients in their ICU. Their intervention was family presence. They had the families come to sessions where they taught them hand-holding, encouraging words, massage. So not only were they present at the bedside, but they were engaged with the patients versus none. They measured vital signs, the family satisfaction survey, and then intubation time. And those were their outcomes: family satisfaction, the vital signs in the patients, and time on the ventilator. So let's look at the results. So if you look at the intervention arm versus the control arm, you could see that everything was better in the family presence arm. They spent less time weaning. They were less likely to be reintubated. People were happier. There was convenience of assessment, and decision-making was better with an overall satisfaction score that was better. If we look at all the vital signs, and I'll just highlight the after intervention, all of them were also statistically significant, with all the patients in the intervention arm having improvements in their vital signs. So moving on then to a study done in a Chinese ICU, they wanted to look at video visitation on patients during COVID. This was a RCT of 121 patients and 98 family members in an ICU in Beijing. And they organized quote, family visitation using video on a social media app that was used at an agreed time, mostly in the afternoon with the families versus no visits, although the families that had no visits were potentially called by the nurse with a change in status of the patient. These were the measurement tools, the anxiety tool, the CAM, the self-assessment, self-anxiety assessment tool for families, and a survey tool that they developed. And their primary outcome was patient anxiety and depression, also looking at delirium, their patient satisfaction, and then family anxiety and satisfaction. So their primary outcome, there was no difference in anxiety and depression between the groups, although both groups went down. It wasn't statistically significant between groups. And in their secondary outcomes, I just want to highlight family satisfaction was the statistically significant outcome. So in spite of the fact that there was no difference in patient delirium, again, invoking other things, no difference in anxiety of families, but families were happier with the care because they were able to talk with their patients or their family members. So moving back to Canada, published last year was this study that was done. It was a qualitative descriptive analysis looking at the impact of the restricted visitation policies on patients, families, clinicians, and decision makers, which I thought was very interesting. You can see the subjects that were there, and these are the results. The acceptance, so their themes were acceptance of the restricted visitation. There was really what they described, what that reflects is a mismatch between what was happening in ICUs and what was happening in the outside world. They talked about how there were conflicts in visitors and wearing PPE. As far as the impact of the restricted visitation, families felt guilt and anxiety of not being able to be there. Clinicians were sad and distressed. They thought it was detrimental to the patients, and both really felt, the families and the clinicians felt like they were unable to support the patients. Trust in the healthcare system on all sides was problematic. Clinicians didn't trust their senior leadership because things did not appear to be transparent to them. They felt that families didn't trust that they were being transparent. Families didn't trust that their loved ones didn't die alone. And so there was a whole bunch of mistrust that came out in these themes. Communication modes, families were delighted that they could have conversations with physicians and healthcare team members over the phone, sometimes via video. And some of the clinicians thought that those video sessions may be disturbing to families. And then the implementation on clinical practice, this is where the decision makers came in. I'll skip the other stuff for the interest of time. But the decision makers said there were challenges in how we made changes so rapidly and rolling those things out. And they noted that there was a problem rolling out changes on Fridays when no one was there on the weekend. So I know that solution, right? Don't we all be there on the weekend with everybody else? But they also offered strategies to improve visitor restriction policies with an increase in organizational support, a centralized place where policies kept changing. I mean, how many emails a day can you actually get that tell you what the new policy is for you to be able to really keep up with it? So devising sort of a central repository where everyone in your institution can go was a really great idea. A patient navigator for our families, and then ICUs just to have visitation, and that's just it, and work out a way to make that happen. So moving on then to another exploratory qualitative analysis done in Norway, looking at family members' needs and experiences during COVID. 12 family members participated after first and second waves. And the overarching theme of this work was coping in times of disruption and deprivation. That was the overarching theme, with other themes as experiencing a double burden, meaning the care of your sick loved one, and being worried about all the other people that are potentially going to become sick because of that, in addition to oneself. Becoming an insignificant other, I was really struck by that language. In pediatrics, the family comes with the patient, so we don't have the family stays away. We can't do what we do without parents and family members, but in adults, that is a very different scene. So being an insignificant other, I found incredibly distressing, even just reading that, and thinking about the empathy talk that, and the compassion talk that we all just listened to, that sort of transition to becoming not somebody that matters at all, to somebody that matters extraordinarily much to someone who doesn't matter very much at all, feeling that way. And then regaining significance. How do you then rebuild your life to now take care of your loved one who's now come home, but is not healthy really yet, and being unsupported and unprepared for that? So Rosa and colleagues published in 2019, and I say that aloud because I want to call people's attention to the fact that it's pre-pandemic, looking at a randomized controlled trial for flexible visitation on delirium in the ICU. And this was a crossover RCT with a 30-day washout, and it enrolled a lot of patients using those measurements. And as you can see, the Maslow burnout inventory was used. So this was not just about patients, it was also about clinicians. So the intervention, the units were randomized either into phase 1 or phase 2. So the intervention arm had flexible visitation with 1 to 2 visitors allowed up to 12 hours a day. And the family members underwent these structured meetings at least 3 times a week with education on helping to facilitate the care of the patient, as well as access to a website and informational brochure. And those who were, when they moved into the restricted arm, those units, they were back to their regular restricted visiting hours. So the incidence of delirium, there was no difference between the groups. And while they did their analysis and looked at sedation level, I didn't see anything in there on benzodiazepine use. I may have missed it, it's possible. But the relative results, everything got better. So if something doesn't get better in patients, but everything gets better in the family that's caring for them and ultimately going to take care of them at home, #PICS-F, should we do it? And then what about in the clinicians? For the clinicians, people talk about how having family at the bedside is going to potentially impact the work that we do, but the clinicians had no change in burnout. So let's look now for just a second at 2 more papers that I'm going to buzz through. This was a survey of attitudes on visitation in Australian ICUs and enrolled over 1,200 participants, clinicians of all types. And they looked at risks and benefits of visitation or open visitation. And clinicians thought that they were at increased risk for burnout, workload, workflow changes, but that was balanced or also contrasted by the building of trust and the aiding of communication with families. And relatives thought that, it might be really stressful. They had infection control concerns. They thought they would be less support to staff in the off hours, but they too felt like trust was improved, there was improved decision-making, and they would have less anxiety and fear. Contrast that to a study that was published in the Chinese literature of 275 nurses and 139 family members. It was a survey of 29 questions, and there were only 6 that had no difference. Clinicians were overall satisfied with the current policy, and their policy is very restrictive. They felt there was more psychological burden to them, the clinicians. They couldn't behave as they normally would. There were interruptions in care. They would spend less time with the patient and more time with the family as a result of having families there. But the relatives felt that they would have more satisfaction, they would get more information and more support from the nurses, and they would be less anxious. So what do we do with all this? So I think in the future we have some opportunities. So there was a recent paper that was published by Zhao and colleagues on using AI to bring family voice to patients. We have to temper everything we do with AI, right? But this may be an opportunity for us to bring family members into the ICU in a different way, different from when I was a brand new bedside nurse in the ICU and I would have 100 years ago, families record reading books to their children and bring in their little tapes so we could play the tape at the child's bedside so they could hear their family, or during dinner time, because like in my family with 7 kids, dinner time was always very animated and lots going on to help kids feel better. And I would also offer that for our future, we need to take into consideration the ethics of what we're doing, and Papademos et al. In 2018 published the ethics of family visitation, using the concepts that are embedded in that work and bringing them into the work as we revise the way we think about families and ICU visitation. We talked about this yesterday in the disaster session, that we're sort of in this spot now where we are rebuilding what we're doing and thinking from all of our experiences. So I would invoke the use of those ethical standards to move forward. Thank you.